author I've worked with for 18 years, Professor Reinstein, has a financial interest in the ArcScan Insight 100, and is also a consultant for Carl Zeiss Meditech. So when you're talking about the epithelium, the best place to start really is the normal virgin eye. What does the epithelium look like in a normal eye? And up until the point we did this study, it was assumed that the epithelium was the same thickness across the whole cornea. And so, we kind of thought, well, we'll average it and see if that's right, not really expecting any result. But what we found actually was that it wasn't. We found that there was on average about 53 micron thickness centrally, but we found an inferior-superior asymmetry of the epithelium of about 6 microns. And we also found a small asymmetry nasal temporal, which was mirrored for right and left eyes. So it wasn't uniform across the whole diameter. So the question is then why? So what we thought about was, well, what's happening on top of the epithelium? Well, what's happening is the eyelid, and you're blinking all the time. So you're blinking, 1,000 times a day. And with the eyelid, you have the semi-rigid tarsus on the inside of the eyelid, and that's then providing a force onto the cornea and onto the epithelium. And if you think about the anatomy of the eyelids, our upper eyelid actually sits sort of just rests on the top of the cornea a lot of the time, and most of the blinking action is coming from the upper eyelid. So it makes sense then that the superior part of the epithelium then becomes thinner because of that. And if we think about this a bit further, what happens if you take the eyelid away and replace it with a contact lens, like you do with orthokeratology? So we looked at orthokeratology, and if we look at the difference between the epithelium before and after wearing an orthokeratology lens, what you see is that there's a huge change in the epithelium because the lens is intentionally shaped not to fit the cornea very well. So it's very tight fit in the central cornea, which ends up with a thinning of the epithelium. And then where it fits more loosely, you get the epithelium growing out to the template provided by the contact lens. So you've taken away the template of the eyelid and replaced it with an artificial template. So the epithelium remodels to whatever template it can grow out to. And this was actually described a long time ago. Alfred Vogt in 1921 said, corneal stromal defects are filled in with surface epithelial cells. And this is what we see whenever we're looking at the epithelium. So for example, everybody now knows that there's huge epithelial changes in a myopic treatment. So if you do a myopic ablation, what you find is there's thickening of the epithelium centrally, and this was shown using lots of modalities in the 90s. But it's more than that. If you look at it across the whole diameter, yes, there's central thickening, but actually, in the periphery, you get thinning of the epithelium. Now, if we look at that region specifically, why is it getting thinner in that region? Well, if you look at under the surface at the stromal change, in the middle, you've taken tissue away, so the epithelium has grown to compensate for that partially. But in the periphery, the stroma has actually got thicker because of the corneal lamellae expanding. And where it's got thicker, the epithelium then compensates for that by getting slightly thinner. So there's a lenticular change in a myopic ablation, which is essentially reversing some of the treatment that you've done. And then obviously, the more treatment you do, then the more epithelial changes you see. So the more you change the cornea, the more the epithelium tries to compensate. So this makes us think, okay, fine, that's myopic ablation. What about another myopic treatment? What about RK? Well, in RK, you see exactly the same epithelial thickness profile. So you see it's thicker in the center, and around the periphery, it's got thinner. But you haven't removed any tissue in this case, so it's not related to tissue removal. What you have done is change the curvature of the eye, of the cornea. So it's responding to a change in curvature. That's what the epithelium is compensating for. And we also know from this study that these epithelial changes are very long-term, they're permanent. So some of these cases in this study were 26 years after their initial RK treatment. What about hyperopic LASIK? Well, it's exactly the same. It's compensating for the change in stromal curvature that you've made. So it's the opposite of myopia. Where it's steeper in the middle, you then end up with thinning of the epithelium, and where you've removed tissue, you get thickening compensating for that. And this goes on every example you look at. So what about keratoconus? Well, in keratoconus, obviously you've got a stromal cone now bulging forward, very similar to hyperopic LASIK, and you get thinning over the cone. And around the cone, you get thickening of the epithelium. So both thinning and thickening to try and make the front surface more regular again. And what you see also is that as the cone becomes more advanced, then the amount of epithelial changes increases. You get more thinning and you get more thickening. And so obviously, there's a very stark difference between the epithelial thickness profile in a normal eye than there is in a keratoconus eye. And so obviously, you can then use that as another way of diagnosing keratoconus. And in particular, you want to try and pick up those early cases where the epithelium can compensate for the cone almost fully. So you can use the epithelium as a very early indicator for keratoconus, which is what we did with these sequence of studies. And with Ron Silverman, we developed this algorithm, which using only epithelial thickness to diagnose keratoconus, we were able to distinguish between the groups of the different stages of keratoconus with very high specificity and sensitivity. And, you know, in the last 10 years, what's really excellent is that this kind of awareness of and use of epithelial thickness profiles is becoming much more widespread because of the introduction of OCT and other now even more modalities measuring the epithelium. So it's really great to see that becoming in common usage. Here's another example published last year, even more progress being made with keratoconus screening with OCT. And so what I'm really trying to say is, whatever situation there is, whatever situation we've ever looked at, the epithelium is always compensating. And we can really describe this with the 4 rules of epithelial healing. And as we've seen, the epithelium will always thicken to fill relative depressions. So we saw that in thickening around the cone in keratoconus. Same with ectasia. You get central thickening in myopia, peripheral thickening in hyperopia. All of these things are filling in the relative depression. The epithelium always thins over peaks. So we saw that with keratoconus. Ectasia exactly the same, hyperopia exactly the same. And also, as we saw, that peripheral thinning, which is kind of counterintuitive in the myopic cases. The epithelial change is proportional to the stromal change. So, as we showed, the more myopic treatment you do, the more epithelial response remodeling there is. Exactly the same thing with hyperopia. So the more hyperopia treatment you do, the more thinning you get and the more thickening you get. And similarly, as we showed, the more advanced the keratoconus becomes, then the more thinning and more thickening you get. You always get both as well. You always get both thinning and thickening because you're trying to, it's trying to create that smooth surface. But the main rule is this last one, which is that the amount of change is driven by the rate of change of curvature, or the curvature gradient of the stroma. So if you think about it like this, if you take a very small diameter defect, you get almost 100% compensation. So for example, you have this corneal ulcer, and you can see that the epithelium has thickened by almost 200 microns, so 4 times its normal thickness. And it's restored that front surface to be almost normal again. Now, if you take the same depth defect, but make it a wider diameter, then you still get compensation from the epithelium, but not as much. So you're down to about 40% now. And this is really kind of what we were seeing in the early 90s with very small optical zones, 4 millimeter, 5 millimeter optical zones. And, you know, that explained why there was that initial undercorrection in those studies and a great deal of regression in the first month or so. So it was completely explained by the epithelium, which in the original papers, it's actually stated that the assumption is made that the epithelium is uniform and it won't change. So obviously it did change, and so we had to make up nomograms to be able to adjust for that change. And then groups like David O'Brien with John Marshall, they showed that if you increase the optical zone, then that greatly reduced the amount of regression. And so this is where we are today. We have nice, big, large optical zones with big transition zones. And so now there's only about, you know, roughly about 20% compensation. So this is kind of where we're at today. And as Ricardo and Paolo Vinciguerra have described, exactly the same concept is the stroma. They explain it as the stromal surface curvature gradient. And so that drives how the epithelium remodels, is the gradient of the stromal surface. So that defines where it's going to get thicker and where it's going to get thinner. And this leads us on to the therapeutic cases. Now, where you've got a case of irregular astigmatism with a complication or something, then you have irregular astigmatism, then the law is that you will have irregular epithelium. And it also means that if an eye presents with irregular topography, then by definition, the epithelium has reached its maximum compensatory function. So it's compensated as much as it can, but it can't compensate any more. Otherwise, the topography would look perfect if it had compensated 100%. Therefore, topography measurements are actually an inaccurate way of measuring the corneal power. So if you consider these three examples where the same front surface, you could have, theoretically, 3 different stromal surfaces underneath. But the front surface becomes the same because of the epithelial compensation. So if you only measure the front surface, you don't really know what's going on under the hood. And so here's just a few examples to show you the kinds of completely irregular, wacky kind of epithelial thickness profiles you can find in irregular cases, where the epithelium is compensating for local irregularities. And just to introduce this concept, this is going to be discussed in much more detail by the other speakers. While this kind of looks scary, actually, it's really useful because you can use the epithelium as a natural masking agent by using a treatment called transepithelial PTK. So with transepithelial PTK, the ablation you're doing is a uniform depth across the whole diameter. So you want to use as large a diameter ablation as you can, so 8 millimeters or bigger than that. Exactly the same depth across the whole cornea, directly onto the epithelium. And what that means is that where the epithelium is thinnest, it will break through and then start ablating stroma in that location. But everywhere else, it's still removing epithelium. So it targets the ablation onto the peaks in the stroma. Therefore, you're going to smooth out the stromal surface. And it's incredibly effective. One of the great things about it is you don't need to worry too much about centration because it's driven by the epithelium masking agent. And so just to show you an example of this in action, here is a case of a central island with a completely irregular topography with this area of steepening. And over that area of steepening, you can see the compensatory thinning of the epithelium. So the transepithelial PTK targeted the ablation into that over the central island. And only by doing a transepithelial PTK, we got this topography afterwards, a completely normal orthogonal astigmatism. And now you can see that the epithelial thickness looks normal as well, because the stromal surface is normal, so it doesn't need to compensate for any irregularity. So you've got a huge change in the topography purely from a transepithelial PTK. Now, one word of warning is when you're looking at epithelial thickness maps, you should also be aware of other reasons why you might get an abnormal epithelial thickness profile. The first one is the influence of contact lenses. We already saw that with ortho-K, but just wearing contact lenses as well can warp the epithelium. So you can get this sort of maybe suspect inferior steepening pattern. But if you leave the contact lenses out, then the same cornea comes back and it looks normal. Another reason is anterior basement membrane dystrophy. So obviously that is a dystrophy of the epithelium of Bowman's layer. So it makes sense that that could result in some strange epithelial behavior. So here's an example of an eye with ABMD, and you can see what looks like a keratoconus pattern of localized thinning surrounded by thickening. But that was actually just due to an ABMD. Dry eye also is another way that the epithelium may change. So in this example, in this inferior portion of the cornea, you can see that there's a significant change to the topography, and that's because the epithelium has got thicker related to the dry eye. The other thing is eyelids. Especially where a patient has a ptosis, they can sit much more on the cornea than in a normal case. And this can result in, again, sort of abnormal looking epithelial thickness profile. So in this example, again, it looks like a keratoconus suspect case. And indeed, our index indicates that it is a suspect case. But if you look at the eyelid anatomy, then you can see that because of where the ptosis and where the eyelids naturally sit, that's completely distorting the epithelium. So all of these things you should take into account as well when you're considering epithelial thickness profiles. So that really kind of gives you hopefully an understanding of what the epithelium's doing, and when you look at an epithelial thickness map, you see those areas of thinning, you see the areas of thickening. You know, therefore, that there must be a peak in the stroma where it's thin and a trough in the stroma where it's thick. So this gives you a view underneath and inside the cornea to really understand and diagnose what looks abnormal on a topography. And these guys now are going to show you how to fix those abnormal corneas. Thank you very much.
Thank you, Tim. This was great. It seems that Michael Moroccan has not arrived yet, so I will continue with my presentation. Yes, I will talk about the issues in planning of topography-guided surface ablation in irregular corneas. I have no financial interest to declare. And most of the presentation will be about deciding the astigmatism endpoint in topography-guided laser vision correction. Even with virgin eyes, we have often this problem about if you use topography-guided ablation, what kind of what astigmatism we're going to treat. So, for example, this is a young 20 years old male with virgin cornea, totally regular, no higher order aberration, but manifest astigmatism is 225 against the rule, while the total corneal astigmatism was only minus 0.93, also against the rule. In this case, where we do not suspect any influence of posterior surface, influence of higher order aberrations, we usually go for treating the manifest astigmatism. And but in irregular cases, things start to be a little bit more complicated. we have to think about the complex relationship between anterior and posterior cornea and interior eye optics and the anterior corneal optics that we measure, as well as the manifest astigmatism. So there's an intricate relationship between all of those three. I will start with one of my first topography-guided cases, orb scan-based topography-guided ablation done in 2005. And this is a 50-years-old lady who was previously treated in the 90s for high astigmatism by incisional surgery. And she presented at our clinic in 2005 with visual disturbances, decreased visual acuity, and cylinder against the rule of 2.5 diopters. It was very challenging to me to start using my new tool, topography-guided ablation, and like most of the people at the time, we did not consider very much posterior corneal surface and the influence of it. And we designed the ablation map. Looked very nice, very complementary to the anterior topography, and simulated outcome looked very nice too. So I was eager to go on with this case. And the topography after the surgery, anterior topography, looked also quite nice. There was almost no astigmatism at some point, at least at 10 months, and very slight withdrawal astigmatism later on. But to my and patient's dissatisfaction, her corrected visual acuity went down from 0.5 to 0.3, and her astigmatism flipped, and it was more than it was with the rule 275, started against rule 2.5, and unfortunately continued to be significant astigmatism with the rule. We were very puzzled by this case, and did in the course of several years all kinds of exams that was possible. And after extensive evaluation and exclusion of all the other possibilities, posterior corneal irregularities were identified as the source of the higher order aberrations causing deteriorated vision and significant subjective astigmatism. It was actually this posterior coma that was very concentrated and had a huge refractive effect, refracting as the anterior astigmatism with the rule. So we know that major morphological changes occur on the posterior surface, especially in keratoconus and post-incisional surgery. And we have to distinguish two situations: when the epithelium when the anterior surface together with the epithelium are compensated for the posterior irregularities and making it less, or the one which is usually opposite case. We have most irregularity on the anterior, and then the posterior is decreasing those. So normally the posterior irregularities partially balance their anterior counterpart, but in some cases, like in keratoconus, they may dominate, and they are actually optically balanced by their anterior counterpart. So we know that removing this anterior counterpart will worsen the situation in this. I did not know about that, obviously, when I treated this patient. A couple of years later, there came some article in optometry journal saying that increased total ocular higher order aberrations and lower visual performance were described in some keratoconic eyes upon correction with rigid gas permeable lenses. This is actually the same situation. We regularize the anterior, and then the posterior optical irregularities jump out and become manifest. So, can we do anything about the dominant posterior surface influence? we know we cannot, at this moment, we cannot treat the posterior cornea by no means. Do not use anterior topography guided treatment, that's for sure, knowing now that we need this anterior irregularity in order to compensate for the posterior. We may choose wavefront optimized ablation if correction by sphere and cylinder gives notable improvement, but probably not treat at all, unless we have a good wavefront map of those cases. And this is our dream, but usually wavefront maps of the highly irregular eyes are usually not good enough to plan our custom ablation upon. We have a couple of future options actually already becoming to be available. Something called the Alcon Indevice, artificial intelligence ray tracing guided topobiometry ocular wavefront. Well, it takes the data from anterior and posterior cornea to design the treatment, as well as the wavefront data. And John Kanellopoulos, if he arrives, he's not here yet, he will talk more about that option. And there is another option by a small Italian company called Ivis. They constructed something called total, meaning anterior plus posterior, corneal ray tracing guided ablation. Since both options are talking about ray tracing, so let's see what we're talking about. We trace a light ray, actually in case of this Italian company, 120,000 light rays are traced through the anterior corneal surface, then through stroma and back from posterior surface to the aqueous, and actual preoperative focusing point is found, and ideal focusing point as well. So this way we know what we have and what we want to achieve. In case we use, as before, topography guided ablation when we want to regularize the anterior surface, we see here that it will overshoot. Our ray tracing point will be focusing behind the ideal point, and of course the surface will be, the total opticals will be irregular. But if an irregularity on the anterior surface is left, just enough to compensate for the posterior irregularity, then we may get the focus in place, and we may take into account the posterior corneal irregularities. So the goal is aberration-free total corneal optics. We start with the total corneal power ray traced map, and then we want to achieve totally regular power map on that cornea. So what we need here is highest quality topography data, in this case 120,000 points per surface, which were the basis for the ray tracing maps. And we want to find the anterior ray tracing, total corneal and posterior, and we will use the total one as our, this is what we want to correct. So what is very important that we start with an existing anterior corneal surface, and we do not want to transform it to the regular one, but to the one that includes the irregularities that will compensate for the posterior corneal irregularities. So it is done by a process called reverse total corneal ray tracing. So just to repeat, we do not want totally regular anterior surface. We want the anterior surface that will result in totally optically regular cornea. So it means the small anterior irregularity is compensated for the posterior irregularity. This option, not only that it takes into account posterior corneal optics, but it ablates actually less. Let's say this is a schematic section of a keratoconus case, and it will be total anterior corneal regularization. This is what would take. This red surface would be the one of the ablation for the total corneal regularization. If you want to do this total corneal ray tracing guided, then we will end up actually with a shallower ablation, because some of the previous irregularities will be used to compensate for the posterior one. So obviously we save tissue this way as well. So this is, in my opinion, way to go in taking into account posterior corneal optics. All these maps that I've shown are taken by this instrument by Italian company IVIS. It's called Precision 2. It's ultra-thin blue laser slit imaging device, which gives us nice anterior topography, nice epithelial map, which is registered to the topography, and then we get also stromal topography, and of course posterior is done there from before. This way, using all this data, we can use this total corneal ray tracing guided ablation, and we can have that, in addition, separately programmed laser ablation of the epithelium and the stroma in transepithelial PRK, which solves the issue of different ablation rates for the epithelium and the stroma. And of course, stromal topography guided would also be possible in this case. So we go to the issue number 2, which is interfering with our topography guided ablation planning, especially this about the endpoint of astigmatism. And we will look at how higher order aberration may interfere with the programming of astigmatism endpoint in the treatment of irregular corneas. We know with our normal refractioning of our patients, we present spherical and cylindrical lens until the patient gets a sharp retinal image of the optotype, and then in case that the eyes also contains higher order aberrations, then our patient will still be seeing distorted image, no matter that the real sphere and real cylinder are corrected. In that case, patient keeps on using sphere and cylinder to compensate for the higher order aberration in that amount that is possible to optimize the image. And that way, the estimation error of real sphere and cylinder is introduced. And we know that when we use topography guided ablation, we know that higher order aberrations are taken care of. But we need to give our software instruction about real sphere and real cylinder. And manifest refraction will not give us this information, because it will contain the patient's perception of sphere and of higher order aberration of coma and spherical aberration, with using a cylinder and a sphere to partially correct those. So we know, and it has been published, that coma is refracting as astigmatism if the patient has a choice of using cylindrical lens, and the spherical aberration is refracting as sphere, and there's publications done in this respect. Our study group was especially interested in this issue, and our late dear colleague Wen Zhou, who was taken by cancer last summer, she presented one article which is part of her PhD thesis, just about this coma influence on manifest astigmatism. She looked into 11 eyes with significant amount of coma and negligible amount of lenticular astigmatism. And then she defined something called discrepant astigmatism, the vectorial difference between the manifest and total corneal astigmatism. And she was looking at a correlation between coma and the discrepant astigmatism. and high correlation was found both in the magnitude and the axis of the coma and the discrepant astigmatism. As a practical product of this was that we concluded that vertical coma refracts as against the rule of astigmatism. So if we have existing with the rule of astigmatism this cornea, it would be decreased by the vertical coma. If we have anterior against the rule of astigmatism on the same eye, then vertical coma will increase the amount of or artificially increase the amount showing on the manifest refraction. With the horizontal coma, the opposite situation. It refracts as with the rule of astigmatism. So eyes that already have some with the rule of astigmatism will refract as having even more with the rule of astigmatism. And the eye that have against the rule of astigmatism will refract as if they had less with the rule of astigmatism. So corneal coma has a significant influence on subjective astigmatism, and we should always take it in account when treating eyes with irregular corneal optics when we're deciding our astigmatism endpoint when we program our topoguided ablation. A very similar case happens with spherical aberration and the sphere. So, to make it simple, I'll talk about as positive, a negative sphericity as a negative spherical aberration because they correlate to each other. So it's easier to understand that if it's a prolate, it's deeper in the center, refracts as myopia, simulates a plus lens on top of the cornea. So we can simply think this way when we have a high sphericity in our irregular cases. And the opposite, if it's very oblate, flatter in the center, refracts as hyperopia, simulating a minus lens on top of the cornea. So whatever refraction we get, we have to realize that our subjective refraction includes the effects of coma concerning the amount of sphere. So I will go finally to the epithelial remodeling, the impact of the choice of surgical procedure. Tim has shown us very thoroughly about the mechanism of corneal epithelial healing, and I will talk a little bit about the impact, optical impact of cornea with and without epithelium. That is corneal, anterior cornea, and cornea with removed epithelium. So we'll show in the upper row epithelium on results on a keratoconus eye, and in the lower row results with epithelium removed, or in this case electronically removed, because this device gives us stromal topography. So we can see here at about the K values, it's like 4 diopters difference between the stromal and the anterior one, which is covered by the epithelium. Astigmatism also very different. 0.28 on the stromal level and 1.28 on the corneal level. Well, this is because some of the coma became astigmatism when giving epithelial remodeling process in this particular case. And considering high order aberration and asphericity, it is always more prolate in the keratoconus side, more prolate on the stromal level than on the anterior level, and high order aberrations are always much higher on the stromal level compared to the anterior level. So all this difference actually is due to this epithelial lens, because epithelium is now not regular. It is thinner in the center and thicker in the periphery, 39 versus some 72 in the periphery. And this epithelium is making all these changes in the measurements of the stromal and epithelial optics and anterior optics. So it reduces stromal steepness and sphericity, It smoothens stromal irregularities and higher order aberrations. This is what epithelial remodeling is doing in keratoconus eyes. But let us look what are the impacts if we have a keratoconic eye or a very irregular eye treated by PRK with mechanical or alcohol-assisted epithelial removal. Our red line presents the epithelial surface or corneal anterior surface, and the yellow line represents the stromal surface. So we can see that those two lines are not parallel. We can see that the yellow line is much more irregular, much higher peak to valley value in the stromal level than on the anterior level. So we start our treatment, take out topography of the anterior surface, the one that we normally do with epithelium on. We design our custom ablation, and then if we remove our epithelium, we meet another geography than we recorded with our topography, because the stromal surface is now much different than the one that we measured. So if you apply topography-guided ablation on this surface, we will end up with still irregularities because we have removed the effect of epithelial remodeling by removing the epithelium, and then we have a totally different surface from the one that we measured. So our stroma is still irregular after this ablation. What can we do with that? Tim just mentioned, and I will elaborate on that. We do transepithelial PTK for epithelial and partial stromal removal in combination with our topography-guided PRK. Either or two separate processes, and some devices here are integrated the two in the so-called transepithelial PRK. So anyway, we start the same way. We take topography, we design our anterior topography-guided custom ablation plan, and then instead of removing epithelium, we program another ablation, which is PTK, for partial stromal removal and epithelial removal. So we program it according to the largest depth of the epithelial thickness, and then we will, in this case, our PTK will include all the epithelium and the stroma, which has been remodeled by the epithelium. So if we apply this PTK, then we will end up with a stromal surface which resembles our anterior topography surface measured by the anterior topography. And in that case, we can safely use our topography-guided custom ablation, because we will end up with totally irregular stroma if everything is good. We know there are some issues with different ablation rate between stroma and epithelium, so the results would not be ideal, but it will be much, much better than if we did epithelial removal mechanically. Our other solution is to do stromal topography-guided ablation. Well, for that we need, of course, anterior topography. We need epithelial thickness map, which will be subtracted from the anterior topography to give us stromal topography. The precondition is that these two are registered, and there are a couple of, actually 3 devices that I know of that will give us a good registered epithelium and topography measurements. It is CSO's MS39, Heidelberg and Anterior, which is just releasing their epithelial map module, and the mentioned Italian IVIS procedure too. Another option is removing the epithelium and taking intraoperative topography, which Ricardo Vinciguerra will show us in his presentation. So in conclusion about this epithelial issue is that epithelial remodeling smoothens the irregularities of the stromal surface. It improves the corneal optics, and we always say epithelial is our friend. But it really presents a challenging situation in topography-guided surface ablation if the epithelium is removed. So we should follow one rule, which is to always ablate the very same surface from which the topo-guided ablation design originates. In this case, we cannot go wrong. So in this case, we will use anterior topography-guided ablation applied directly on the epithelial surface, PTK, PRK, or trans-PRK. Or we can use the stromal topography-guided PRK applied on stroma after the deepitalization. So if we deepithelialize cornea, we must use stromal topography-guided PRK. So I will end up with just summarizing what is necessary to safely use topography-guided laser vision correction in therapeutic cases. First, we must understand the complex relationships of the ocular optics. We must understand the origin of the manifest refractive astigmatism. We will look at all astigmatism components, ocular astigmatism, anterior, posterior, lenticular, higher order aberrations, and their interplay intricate relationship will give us explanation for the manifest refraction that we have and give us a clue what the astigmatism endpoint we should use. So important thing is that manifest refraction is expressed only by lower order aberration sphere and cylinder. So higher order aberrations, common secondary astigmatism can be mistakenly interpreted as increased or decreased cylinder. We covered that, I just repeat. And we should analyze the total corneal refractive map and the whole eye wavefront. We must be confident that correcting anterior corneal coma or other aberrations is going to be beneficial for that eye. If there is something on the posterior, it really is wrong to regularize the anterior cornea because of that. In the worst case, the posterior cornea higher order aberrations that cannot be corrected by the anterior topo-guided laser vision correction may be balanced by the irregularities on the anterior cornea, and we do not want to remove those like I did in my early topography-guided case. And finally, we analyze the epithelial map, take strongly into account the effect of epithelial remodeling when planning the surgical approach, especially if surface ablation is planned. So I made a little decision tree about anterior topo-guided ablation. We need high quality topography, good centration, coverage, repeatability. If not, then it's a no-no for topography-guided ablation. We further need to understand the origin of astigmatism by explaining the cornea topo wavefront and ocular wavefront analysis, and to know what we are treating and to correctly decide our astigmatism endpoint. And if that is also okay, then we have to also estimate the lenticular astigmatism. If it's less than 0.5, we may treat the total corneal astigmatism. But if it's more than that, then we have to do a vectorial addition to the lenticular astigmatism to the total corneal astigmatism to get that endpoint. Well, that was my presentation. We will now continue with Ricardo. Thank you.
Thank you very much. And thank you again for inviting me in this amazing course. So I'm going to try to explain something very complex in simple concepts. And well, this is my financial disclosure. None of them are relevant for this talk. First of all, I'm going to speak about which kind of eyes and corneas we face when we want to regularize a cornea that has some kind of irregularity. First of all, so this one is the easiest one to fix. You have a localized irregularity with a very good thickness. More complex, you have an asymmetric cornea with irregularity, such as decentered optical zone or previous corneal ulcer. Try to remember the topographies because I'm going to go through the cases during the presentation. Then you have more complex ones, so you have irregular corneas all over the surface with good thickness. For example, tromos or keratotomies. And then you have the most complex one, which are irregular corneas all over the surface with low thickness. And we will go through how to fix each of those. The first thing we are all trying to convince you is that somehow it's worth treating this patient in a tailor-made, so you cannot treat all irregular corneas in the same way. Either you look at the epithelial maps and you consider how thick the epithelium is, or you do the topography, but don't treat every patient in the same way because you will fail. Because one size does not fit all. Other examples, I'm pretty sure you will not implant a 22 diopters IOL in every patient, or the same ablation for every refractive patient, same graft size, or the same drop for glaucoma. So in therapeutic treatment is the same. We have to make every treatment different. So we need something customizable, reliable, safe, with possibly quality checks. And, well, if we can, one shot in one day. If it is not possible, no. So let's go through priorities and myth busting. Well, the first priority is setting your priority, because you are treating a cornea in which you cannot do everything. That is the first thing you need to accept, because most of the time is you that you have to accept that you cannot fix all, not the patient. The patient is happy. They just want to be treated. You have to explain them what are your priorities. So first priority that you have to remember is that irregularity is your priority. This is what you have to fix, not the opacity. If you have an opacity that goes through the cornea that is compatible with a good vision, maybe you have a decrease of contrast, but still a good vision, whether if you want to do everything, refraction, opacity, and irregularity, you're just going to do a graft at the end. I'm going to show you an example that shows you that opacity is compatible with very good vision. Our sunglasses on the right-hand side are completely opaque, but we know that we can look through them. On the left-hand side, you have ground glass that is perfectly transparent but irregular. And it's the same thing for the eye. If you have an irregular eye, it won't see. If you have an opaque eye, like the one on the bottom right, which is a granular dystrophy with good surface, they can still see 20/20. If you do cornea, you know that some of your patients, you don't even know how they see, but they do, so it doesn't matter. So second priority, you remember what Alex just explained us, the point of sometimes high-order aberration are influencing your refraction. So that's another take-home message. You cannot fix everything at the same time. You cannot fix high-order aberration cylinder sphere for the same reason. First, you're going to do a DALK at the end. Second thing is because you might even make things wrong, as Dr. Stojanovic showed us. So you have to look at everything at the same time. You have to memorize where high-order aberrations are, because this is how you want for your ablation to be. You remember the high-order aberration, that's how your ablation map should be. And remember how the patient sees, because you want to remove what is impeding the patient to see. So we want a custom approach, and we have to show you how to use topography, which is the only instrument that somehow can customize our treatment on the cornea, even with all the issues that we have with topography, because we're measuring with the anterior surface with an irregular epithelium, etc., etc. So we have somehow to use topography. So first of all, I hope that the first take-home message of this course is, please do not do a plano PTK after removing the epithelium. So that's the first thing. If you remove the epithelium, don't do a plano PTK, because you're just going to deepen the problem, nothing else. So that's the first take-home message. Do not remove the epithelium. The epithelium is our friend. So we need somehow to customize. We're going to speak about how to use the epithelium as a friend and also how to use the topographer. As Alex showed us, sometimes if you do a topography guided ablation with the epithelium on, you're not going to treat everything because of the problem that you have something that is smoothing things out. And that's why we do intraoperative topography. This is our way to solve the problem. One of the first questions I received, this is coming from ResearchGate, is how can you take an accurate intraoperative corneal wavefront after you have removed the epithelium? And I'm going to show you. So we do the ablation, we put a drop of masking fluid, and then we just acquire topography with your normal instrument, such as the CSO, without any difference. I'm going to show you. So this is the wet PTK. It's just a simple wet PTK, but just to show you the technique. I'm so glad that the video is working. And now, this is a patient with an actual intraoperative measurement. So this patient doesn't have the epithelium on. So it's already ablated. So we brought the patient back to our topography system. We have put a drop of masking fluid, and you will see the keratoscopy, how regular it is. And this is reliable, because with these measurements, we do other topography guided ablation. So of course, now the point is, we have removed the epithelium, we have somehow regularized stromal shape. If we have some other irregularity, we can take care of it intraoperatively, because we don't have the masking problem of the epithelium anymore. That's another one, just going to skip it. It's the same, it's another patient. Well, then the other question is, well, very nice, but can we trust it? I'm going to show you an intraoperative topography map when we are happy. So this is when we finished our treatment, and this is 1 week post. You can see that is reliable, is similar. Obviously, it will not be exactly the same, but is reliable. And this is just larger. So I think that the second take-home message is, let's use the epithelium, right? So transepithelial is our second take-home message. Because it's possible to use the epithelium as if it is the stroma, as Timothy said, and we can apply custom ablation to epithelium to regularize everything. Obviously, you need epithelial maps, but now, there are so many machines that can give you this, so there is no excuse. Okay, let me explain you why. First of all, stromal guided ablation, it will be difficult to achieve like a pure stromal guided ablation. Well, first of all, even the companies that have the possibility to track the epithelium and have the stromal pachymetry map, which is available on the market, they do not show at the moment the shape and the elevation of the stroma. And the reason is not because they cannot have it, but it is because it's much more noisy. So that's the problem. It's more complex to track stromal surface. So it's more complex to treat on the stromal surface. And that's the reason why it's more complex to treat at the moment with just using stromal guided ablation. That's another issue. Imagine that you have one of those super complex cornea and you have to regularize it. If you use a transepithelial approach, you accept to use the epithelium as your friend here and leave it as it is. Imagine to speak to the laser, and this is something that Tan is always saying, Jerry, think like a laser. If you think like a laser, the laser will do this. Perfect shape, no problem. The problem is that it's a bulk. And now, I'm going to show some mistakes that we frequently do. Rush discussion with patient, superficial knowledge of laser software, superficial evaluation of the quality of pre-op exams, small optical zone to save tissue, avoiding to correct high-order aberration, and ineffective and clumsy way to use refraction. I will speak one by one. So rush discussion. Sometimes we want, and maybe because sometimes it's our complication. Imagine that you have a patient that has a decentral optical zone and the patient does not see. What you want to do is rush and fix the complication. And maybe you're not explaining to the patient what you can achieve and what you cannot achieve. So that is something that you have to do. You have to explain to the patient what you can achieve and what you cannot achieve. Because if you do that, and I'm going to show you one case in the end, which is a friend of mine that I treated, and I will show you that the outcome was very good, but I will tell you what I told him before treating. Second thing, I hear so many times some colleagues that are saying, oh, I really don't know how my laser is working. I have the technician that is doing the shot file for me. Well, that's a problem. If you want to treat an irregular corneas and you don't know how to do a shot file, don't treat. Full stop. Or use a small optical zone to save tissue. That's an issue because we want to regularize a very irregular cornea, and you're saying to the laser, please just regularize in the center. Remember, think like a laser. The laser will not say, warning, this is a problem. It will just regularize the center. But sometimes this is not working. So I'm going to show you this patient. Of course, if you increase a lot the optical zone, you will lose too much tissue. But imagine here. So here we are moving from 6 millimeters, okay? You're just, a smaller optical ablation diameter is only 60 microns, but you do not fix everything because all the irregularities outside of that. Well, then you say, well, you're telling me that I cannot treat small optical zone, and now I'm going to tell you that you have to treat all high-order aberration. That's another problem, because then you have to ablate more. So then you're going to tell me, well, very nice, Ricardo. You tell me to use large optical zone to treat all high-order aberrations, so how do I avoid doing a bulk? You either can use some ablation software, like the Schwind one. I have no financial interest, but the ablation software of the Schwind lets you make a compromise. So if you want to treat just high-order aberration, they will optimize the refraction settings to reduce the amount of ablation. But you can still do it just if you think like a laser, again, by adjusting your refraction settings. Let's go back to this patient. So if you tell to the laser, regularize, and the refraction is minus 3.50 at 20, they will regularize high-order ablation, plus you have the torus, the cylinder. Imagine that you say to the laser, this patient is has no cylinder, is hyperopic. The laser doesn't know. What will the laser do? Will ablate in the periphery, which is what you want, because your cornea is thin in the center. You want to ablate the periphery. So you're telling something wrong to the laser to let your laser ablate where you want. Obviously, then the refraction will go all over the place. But we are refractive surgeons. I mean, we fix refractive issues all over the time with no problems. Why it should be a problem after this? You can do an ICL, you can do a refractive lens exchange. So that's another take-home message. Do not remove the lens before regularizing the cornea. Okay, this is a friend of mine. I have two cases. I'm going to show you this one. If we have some time, I will go with the second one. You tell me, right? So this is a friend of mine, and is the brother of a lawyer that was treated for -4 with a PRK with an horrible A's, really horrible A's, and came to us with this cornea. And this is the post-op. Let's go back. So you say, well, this is the cornea, right? And this is the post-op. You got a very good outcome, but my decision tree and what I told to the patient is, listen, you have 190 microns of healthy stroma. and you have 180 microns of scar. We have two options: transplant or try to regularize the cornea. 100% your refraction will get worse compared to how your glasses were before PRK. So that was what I told to my friend. My aim is to let you see again, to let you see your 20/20 again, with or without glasses. This guy was lucky because in the end he has a refraction like objective refraction around -1.2, but he's unaided 20/20. I'm not really sure how, but he's unaided 20/20. Good for him. But you see that we have a very deep anterior chamber. I already thought that if he was going to be too anisometric, I could place an ICL with no problem. So the idea is to fix the issue, the irregularity, not the refraction. And he's very happy now. He's more than, I think it's 8 months without steroids at all, with absolutely transparent cornea. And you can see the differential map. So this is the pre-op and this is the post-op. Now it's very wide. This is the ablation. You can see that we had to ablate a lot. It was around 200 microns of ablation, but remember that the scar, so the haze was 180. So at the end, we ablated 40 microns of healthy stroma. And that's, again, if you have an irregular astigmatism, you're going to have an irregular epithelium on the left-hand side. If you regularize the stroma, you're going to have a healthy and regular epithelium on the right-hand side. You can see the difference in the thickness of the epithelium. That's another one. This one was done by Paolo instead. It's post-hyperopic PRK, which is one of the most challenging one to fix. This patient was +7 -3 pre-op. So remember what Alexander told you? Imagine that you place to the laser this refraction setting plus high order aberration. Is a disaster. You cannot place this refraction inside because you have high order aberration that are making the refraction of the patient all over the place. Just forget the refraction in this case. And also you have to remember, again, think like a laser, where you want your ablation to be. You want to be here, where you have the scar. So this was the pre-op, and this was the first step of the treatment, which we were quite happy. But you see what is our refraction setting? Because we asked to the laser to minimize the amount of tissue removed. That is the intraoperative tangential map. It already improved a lot, but we wanted to go more because we wanted to improve this and this. So we obtained this treatment file. See how much is the ablation. So the first ablation is 104 and 150, including the epithelium. So with the first shot, you can ablate a bit more. But the other shots, they need to be much more refined. So you see 11 microns and 20 is nothing. But you see how much the shape is already improving? Then another one to ablate here of 11 microns. This was already very good to me. I remember that when I've seen this shape, I talked to my father and I say, listen, it's perfect, just leave it as it is. And he did another one, and it also improved again. I would have stopped here. I'm less good. But see how the shape improved in the end. So this patient has 0 coma, whether before it was 2.90 microns. So of course the patient is +5 now, because that's the only way you can solve the problem. You cannot remove the hyperopia as well. Toric IOL was done, and the patient now is unaided. Thank you.
Thank you, Ricardo. Yeah, at the end we will look at the video from Arthur Cummings. Yes, his narrated presentation.
Thank you, Alex and team, for your kind invitation to speak to you on therapeutic laser refractive surgery and treatment of corneal optical irregularities. My financial disclosures are here, with wave light being the most appropriate. Generally, I think of corneal irregularities in terms of previous keratorefractive procedures, keratoconus, and corneal injuries. Small decentered optical zones and larger, significantly decentered optical zones make up the bulk of complications in keratorefractive surgery. Keratoconus and central keratoconus are also optical irregularities that can benefit from laser surgery. Fourier analysis is a very good tool to demonstrate just exactly how significant the coma is and how significant the decentration is. So the laser tools that we have to address this is topography guided ablation, wavefront guided ablation, transepithelial PRK, whether we use the wavefront optimized profile or a topography guided profile. And we can also address irregular astigmatism with LRIs, with a femtosecond laser. So first, looking just at the tool of PTK with the wavefront optimized PRK. As the PRK commences, the laser beam comes down, impacts the epithelium, starts going through the epithelium, and eventually breaks through the epithelium. You're now getting into stroma. Over here is still working in epithelium. And it goes deeper and deeper, taking away more stroma, and eventually, once the PTK is completed, there's an area that's been removed of the stroma that has an irregular shape. And this is in fact a topography guided shape thanks to the epithelial masking. If, however, you do a transepithelial topography guided ablation, you have even more effect. So the same process is happening with the PTK, and the PTK is moving this area of tissue. But now, the information that you got from your topography that's going to drive the topography guided procedure is now applied to the stroma, and now you address. There's an example of a case of a truncated flap that happened 6 months earlier. An ablation proceeded on the left eye instead of stopping, and was left with a very unsatisfactory outcome with base corrected acuity of 6/20. The untreated eye was fine. The treated eye, one can see the area that was ablated and the area that was not ablated, that is steeper. And on placido disc, you see the same thing, the steeper area, and then the flatter area where ablation took place. Flap stria were present, so the first thing that we did was to suture the flap. And 1 week post-suturing, there was an improvement in the appearance, and the base corrected acuity had improved to 615 minus 2. And 3 weeks post-suturing, it was more regular again, and now the vision had improved to 6/10. One can see the same changes on placido disc. 8 weeks post-suturing, we now have a base corrected acuity of 607.5 minus 2. And again, it looks more regular, especially looking at the profile. Some 6 months later, a PTK is performed with a topography guided PRK, so a transepithelial PRK. And 3 months following the PRK, the vision is now 6/5 plus 1. The cornea is far more regular, and one can see the same thing on placido disc with a very good profile. 6 months later, it looks even better, and now looks as though there was never previously a problem. The second case is a 46-year-old male who had laser surgery 25 years earlier and had started wearing glasses again 7 to 8 years afterwards. he went back to the original surgeon who declined to do any further surgery and came to see us to decide whether anything could be done. We decided the best solution would be a transepithelial topography-guided PRK, targeting 0 in the dominant eye and -1 in the left eye. He was warned that there would be a 20% risk of requiring an enhancement at 6 months. So the transepithelial topography-guided PRK was done to both eyes in January of this year, targeted 0 on the right and -1 on the left. And very recently, the enhancement surgery was done using wavefront optimized profile on both eyes. The right eye above, following surgery, sees an expanded optical zone, and the left eye sees an expanded and centered optical zone. On the pseudo disc, on the right eye, you can see the previous preoperative situation, now with an enlarged optical zone, and the improvement from this profile to one that is more regular. On the left eye, you can see this very irregular profile that is improved drastically, and in the visually active visual center, there is now nothing more than a bit of astigmatism that needs further attention. So the refractive effect with a wavefront optimized is typically 15 microns centrally, and going out to no microns in the periphery equals 1 diopter. But when doing a customized procedure, you often find that there is ablation in the periphery with a differential ablation centrally. And even though this is double the ablation of the one on the left, it still only has a power in refractive sense of 1 diopter due to the differential of 30 versus 15. We are all very familiar with the corneal epithelium, and it is normally fairly homogeneous. What happens if the thickness centrally is different to that of the periphery? Well, the truth is it then behaves like a contact lens and has a refractive effect, and this case will hopefully show this. 54-year-old female at LASIK in 2007, had an enhancement in 2017 from -150 -1 in the left eye. Both eyes were in this facility. One eye only was treated to initiate a monovision solution. The epithelial maps on the right eye showed central epithelial thickness of 67 microns, and this was consistent on all the maps. On the left eye, the epithelium was 63 microns thick and 64 microns on a second scan. The post-operative results were as expected on day 1, 20/25 uncorrected. Even week 1 looked good at 20/30 uncorrected distance visual acuity. At 1 month, the epithelium was 52 microns centrally, where previously was 63, and we had this overcorrection with a poor endpoint at 6/20. The post-operative course didn't improve. In fact, it got worse. At 2 months, it was +2.5, +1. On 3, +350, although the base corrected acuity was improving. Then things started improving slowly to +150, remained at +1 at 6 months. At this stage, I was prepared to go and make an adjustment, but the patient felt that things were improving and asked to wait another couple of months. And at month 8, for the first time, she was now correcting to 20/20, but still overcorrected. These are the epithelial maps at the same time. 51 microns centrally at month 2, 53 at month 3, 54 at month 4, 60 microns at month 6, and 63 microns at month 8. So now we have, for the first time, the same epithelial central thickness as we did pre-operatively, yet we are still overcorrected. And the reason for this has to do with the shape of the epithelial maps. You can see this has a bit of a hyper. We can also use the femtosecond laser to do astigmatic correction with corneal incisions. LRIs can break the surface or be intrastromal. They can be superimposed on the topography and placed where the surgeon feels they are most appropriate. The incisions can be coupled and remain diametrically opposed, or they can be uncoupled and placed on different axes, or one incision only can be used, the second incision turned off, providing a lot of customization options. The femtosecond laser also detects the pupil and limbus detection and registration, making the placement of these incisions very accurate. Keratoconus is also an indication for PRK, and in keratoconic cases there is always flattening of the steep area and steepening of the flat area by doing a semicircular zone peripheral to the flat area. And on these examples you can see them repeated on every one. And here we have a treatment driven by Schine fluke and one driven by placido disc, and they basically look exactly alike. This is the case of keratoconus treated with transepithelial PRK, and this is directly post-operatively with a huge improvement in regularity, and this is the difference map with a significant steepening of the flat area and a flattening of the steep area. The fellow eye shows a similar story with a significant improvement following the initial surgery, and the difference map showing steepening of the flat area and flattening of the steep area. Finally, I'd like to discuss thermal procedures, even though they aren't laser surgeries. We're still doing CK procedures on occasion for keratoconus, and we see an immediate improvement of the irregularity directly after the CK placement, and then cross-linking is performed the next day. This case shows flattening of the cornea thanks to these CK spots. This is a case where the steepest point was at 82 diopters. After one CK spot, it flattened to 64 diopters, and after 5 CK spots was much smaller and flattened down to 58 diopters. Epithelium on cross-linking is then applied 24 hours later. It's safe. It allows eyes with very good vision to be treated thanks to a safety profile. There's a quick recovery, and 50% show a one-line improvement in visual acuity. We finally have this article published in Clinical Ophthalmology, and the references are attached. Also very recently published in Cornea, 30-year follow-up of CK for keratoconus, but without cross-linking. What can be seen here is where the spot needs to be applied. The spot is applied and the Myers look a lot more regular, but you then apply more in order to overcorrect, because you know there's going to be regression overnight before the cross-linking is applied. So in conclusion, topography-guided PRK is a very useful tool to treat corneal irregularities. Transepithelial topo-guided is even more effective, and CK plus epion cross-linking for keratoconus or ectasia is a safe, effective, non-invasive method to improve vision in select patients. Many thanks for your attention, and enjoy the rest of the course.
Yeah, this was the last presentation, and if there are some immediate questions, we have a couple of minutes left. If not, then I would like to thank the audience for their participation. Thank you very much.
Just before you go, if you are interested in this topic, we have 2 more courses in this topic. So tomorrow morning at 9:45, if anyone has a case that they would like some opinion on from Alex and Professor Reinstein and some of the other faculty, that we're running a live bring your own case course. So if you are interested in presenting a case and discussing it live with the faculty, if you want to catch me after now, we can sort of get that sorted out for you. So come along at 9:45 tomorrow, and then also Monday morning at 8 a.m. We have Professor Einstein and Lund Vision Clinic doing a therapeutic course as well. So make sure you come along to both of those. Thanks a lot.